Just another 30 seconds. So our today's lecture will be on Kati Shoola, also called as lumbar back pain. And my main heading is meeting has been recorded. And so a very good evening to one and all. Myself, Dr. Nikhil Gupta, MS Shalya Tantra, and thank you all for joining this session today. So today we are going to deal with lumbar back pain, that is called as Kati Shoola. Sorry for the delay. And now I'll be sharing my screen and starting the presentation. We have been 5 minutes late now today. Om Dhanvantaraye Namaha. So before starting this presentation, I would like to sincerely thank my parents first, then my teachers, my mentors, my gurus, my colleagues, and my dear juniors who has constantly supported me and made me that strong. So my heading is Kati Shoola Lumbar Back Pain, and this is the 10th session we are going to start. So today we have learned actually the anatomy, physiology, and the working of spine. But today I'm going to teach the clinical correlation of anatomy and physiology of lumbar spine specifically. So on the left side of an image, as you can say, this is a Burj Khalifa. And you might be thinking that what it has to do with spine. So the structure of Burj Khalifa teaches us two things. First is, can you see the lights being thrown out from the building? It resembles the nerves coming out from the spine. And second thing, if you see the building ka base is very thick, broad, dense, and strong. Same goes with our spine also. If you see the lumbar spine, this lumbar spine is always thick, dense, broad, and made to lift the weight. So all the pressure of your spine is onto the lumbar vertebrae. So here we can see that there is a tower. Tower may say there is electricity coming outside and supplying to different part of your bodies. You can correlate this tower with your spine, whole body spine, whole spine. So how clinically it is correlated? So when the patient comes, you have to first see the structure, the posture you say. Normally, the shape of a lumbar is in lordosis shape, but it is slight lordosis. But if there is any abnormality, you see that you see in the X-rays and reports that there is inward curvature, that is outward curvature, there is loss of lordosis on lumbar spine. It is noted as that way. So in the right hand side image, you can see this is the normal shape of a spine. And on the another patient, you can see the patient ka belly is coming outside. His spine is more in the lordosis shape and buttocks are coming out. So this is an improper posture which needs to be corrected. How we'll teach you in further sessions. Next is, see, this is a 3D image. This is a 3D image of all the 5 lumbar vertebrae along with intervertebral disc. I think everyone knows this, but how to clinically correlate? So there are two things to remember. First thing, when you touch at the center of your spine, that time you see this spinous process has been felt with your fingers. Can you see this? Can you appreciate this? Yes. So we need to know the anatomy. Why? If you see while giving spinal anesthesia, we identify the spinous process of lumbar vertebrae and give accordingly spinal anesthesia. So there are two types, high spinal and low spinal anesthesia for different cases and different surgeries. So this is how you identify clinically. Next thing you need to notice that, can you see this, appreciate this light blue color? This light blue color is called as facet joints. Facet joints, why it is important, I'll share you in another 5 to 10 minutes. And this bright portion is responsible for arising of nerves. So any problem to this portion will give you many problems. And second thing, you need to see these two things while palpating. Okay, so here I've put a image of Jim Jam biscuit. So everyone might be thinking, what is this? So when I was eating this biscuit, I came to know that जो white portion है, that white portion is, just suppose, understand it, that is a cream, right? But when you see the biscuit is hard and beach mein there is a red pulp. So that red pulp is called as nucleus pulposus, and the outer tough biscuit part is called as annulus fibrosus, just because it is hard. I'm correlating this with what? With the anatomy of intervertebral disc. Intervertebral disc क्या होता है? Between two lumbar vertebrae, between two vertebrae, you see a shock absorber. This intervertebral disc has a work of absorbing the shock. So can you see this blue picture? This is nucleus pulposus, and the outer tough part is annulus fibrosus. If there is any injury, trauma, degeneration, or any kind of pathology in this part, you will see certain signs and symptoms of lumbar vertebrae. So this is how I correlate with the red pulp and the biscuit with this annulus fibrosus and the nucleus pulposus. Next thing you need to know that behind only there is a spinal cord which needs to be taken care of. So posteriorly it is supported by spinous process. So you won't get injury directly to the spinal cord from the center. But can you see these nerves arising outside? Can you appreciate the spinal nerves arising outside? Yes. So this is a correlated with lighthouse. जब पानी में lighthouse रहते हैं, as you see this, lights coming out from the lighthouse. Same are spinal nerves. Our human body is designed so beautifully that you can correlate each thing with something. So this picture tells us that again the 3D image, but I need to focus you on the right bottom corner. Can you see this? It is written annulus fibrosus. मतलब जो side का part है, that is fibrous part. I see that there are little bit of mistakes, but in image you can see the second image shows that there is a little bit of crack in this annulus fibrosus. It may be traumatic, it may be degenerative, it may be any pathology. But after this, if this gets more proceeding, then this fibrosis, annulus fibrosis, gets opened up and your nucleus pulposus comes out. This gives rise to disc prolapse and herniation. It is somewhat like jelly donut shape. So annulus fibrosis, nucleus pulposus, everyone knows about the vertebra, right? This is the vertebra. This is the spinous process. This I have told you the light blue is facet joints. अगर बोन्स में जानना है लंबार में तो ये तीन चीज याद रहना चाहिए. सेकेंड चीज about the intervertebral disc, two things: the annulus fibrosus and the nucleus pulposus. Third, so this is as I live in Mumbai, so we have this Bandra Worli sea link. So this Bandra Worli sea link reminds me of a structure, spine. How? Let me show it to you. See, these are the erector spinae muscles, right? If you keep our spine one above the other, these 33 vertebrae are kept in a length, right? So if you don't support this with something, it may fall towards right. If you don't support it, it will fall towards left. This erector spinae comes in the picture. This erector spinae comes in the picture where it supports your spine. It doesn't left it to go right. It does not help you to go left. Same as this bridge. If you keep the road, if there is only the road, so because of waves, it may have the tendency to break. So this long structure is the spine. You can correlate it with the spine. And this steel tars with which it is attached is supporting this spine or this structure. So these are the erector spinae muscles which support you. Now this erector spinae muscles consist of three muscles actually. जो innermost muscle है, that is called as spinalis muscles, पतला है. In the middle you get this longissimus muscles, and in the outside you get this iliocostalis muscles. So these are the three sets of muscles that help your spine to keep erect. So how to clinically correlate is my topic, right? So we know this anatomy. So the patient usually comes with a pain in this certain areas where I have marked crossed and red color. It shows the center of pain. Patient can, when the patient complains you कि मुझे यहाँ पे pain है, so the patient, the doctor should come to know that this is the erector spinae muscles being some pathology where the patient is having pain, as we can appreciate in this 3D photo also. Clinically, we we do with the karma, we do agni karma. We take carefully in mind that this muscles needs to be stimulated. These muscles need to be removed the knots and further been stimulated. So my next my next insights will be: is your patient suffering from chronic low back pain? Is it the multifidus muscle? Always the suspect. अब हम multifidus muscle होता क्या actually? See, if we split the term, multi मतलब बहुत सारा, many, and fidus means split. A muscle is getting splitted. So the multifidus muscle, as you can see in this picture, it is getting splitted outside. So this is the most commonest OPD case you will get in your students, and PG scholars might learn this from now, but practitioners are always knowing these things. कि chronic low back pain का patient are always common in old age patients. कि हमें कमर दर्द हो रहा है, हमें कमर दर्द हो रहा है, but which muscle is being acted? Do you ever know? This is the multifidus muscles which needs to be clinically rememberized by all the future practitioners who are being present over here. Thank you so much. And have you ever heard about the multifidus muscles? See the anatomy, how it is getting splitted. So because of this fidus only, it is named as multifidus, multiple splits in the muscles. So this is the major reason of the chronic low back pain in all the patients you see. So how to clinically correlate it? The main reason for chronic low back pain is the multifidus muscles. See, in the first image, we see that muscles contains water. And when you see in the MRI image, can you appreciate this muscle? It is full of water and full flexible, full stretchable. But if there is any atrophy, can you see the size has reduced in just the mild atrophy? And can you see this white thing? Can you see the atrophy in this image? See, if we go to the moderate also has this thing. See the muscles, how much atrophy they had, how much atrophy is there. So the patient is not able to bend forward, do the flexion, do the extension, do the sideways bending, do the rotation. ये सब चीज में पेशेंट को प्रॉब्लम्स आता है. सो इट इज यूजुअली इन द क्रोनिक लो बैक पेशेंट, लो बैक पेन कंप्लेन करके आते हैं, तो वो होता है मल्टीफाइडस मसल्स. इट इज वेरी क्लिनिकली important. So I am speaking about this topic so much. So lumbar spinal muscles, as I have spoken about the erector spinae muscles, we have spoken about the multifidus muscles. And as we know, the weak multifidus muscle is equal to chronic low back pain. It is a very common clinical OPD findings. And the third muscle is psoas major. Can you see this? It looks like a octopus ka tentacles. I'll show in the another image. And can you see this multifidus muscles side से कितने पतले होते हैं and कितने multiple होते हैं? Why the patient is complaining the chronic low back pain? because these muscles are very thin and multiple होने के वजह से during excessive movement, ज्यादा काम करने की वजह से, if you see the labor workers, the construction workers who do very hard amount of work, they always have complaint of this chronic low back pain. They are the most commonest patients in your OPD where you will see. So we'll go with the right image first. Can you see this 3D image of psoas major muscles? Yes, this is a psoas muscles and it arises from the lumbar. It touches your sacrum also. It touches your pelvis also. It moves till the femur. Till the femur it moves. So if you see this on the left hand side, I have shown this muscle. This is a psoas muscle, right? अब psoas muscle में से if you see the most important, can you appreciate this genitofemoral nerve which I am showing? Yes, this genitofemoral nerve is passing through between the psoas muscles. So if there is any stretching pain, if there is any stiffness, if there is any soreness, if there is any spasm, straining or any of those muscles का अगर ये सब पेन है, स्ट्रेन है, स्ट्रेस है, सोर है, स्पाजम्स है, so usually they do irritate the nerves because of this. Agar there is, if there is stiffness, so obviously it will irritate the patient's nerves. This is one psoas muscle what I wanted to speak. Second thing, if you see, my main focus will be on the genitofemoral nerve I've explained you. Next is the obturator nerve. Can you appreciate this obturator nerve? It is coming from behind and just below psoas muscle. So if there is any psoas muscle issue, see, if you see in the right image, वो हमारे पीछे है, बैक में है, और पेशेंट यूजली यहीं पे कंप्लेन करते हैं कि हमको प्रॉपरली वहीं पे पेन होता है, at the pilonidal cleft you can say. So this is the pilonidal cleft where the patient complains of these 2 points. यहाँ पे कमर में दर्द हो रहा है करके. So obturator nerve supplies the sensation to the medial part of the thigh, whereas this lateral femoral cutaneous nerve supplies to the outer part of the thigh. So these two nerves are very important. Ki any nerve compression will give to the two symptoms, numbness and tingling. So this is the third image which I am showing you. The anterior cutaneous nerve, femoral nerve to the front part, lateral cutaneous nerve to the lateral part, and obturator nerve to the medial part. This is all about psoas muscles. If you see, this is an image taken from Williams and Wickens, which tells us that the patient usually complains of low back pain. Bole to this comes into the low back pain, right? This comes in the low back pain because of excessive wear and tear, because of excessive mechanical work, because of excessive stress and strain repeatedly. These muscles get soreness, these muscles get strained up. And this is also one of the muscles which gets, you can see in your OPD correlated with, and these two things are correlated with this psoas muscle. Can you see this in the image? Arising from the lumbar pain, the pelvic part, and the femoral part. These are the three main complaints of a low back pain patients. They can say anywhere. So for the most important thing for the OPD which you need to know is the spinal nerves. So before going to this image, let's jump to the right hand side table first, right? So the table shows L3, L4, L5 and S1, where L5 and S1 sciatica nerve arise hota hai, and L3, L4 nerve gives rise to femoral nerves. अब आपको femoral region में पेन है कि sciatica के region में पेन है, that will come to know through these functions. Ankle reflex. When you ask the patient to rotate their ankles, the patient will feel pain. So you can elicit that this is S1 nerve getting irritated. If you ask the patient to do big toe extension as much as possible, there will be a stretch again in the sciatica nerve which is arising from the L5 vertebra. So clinically, I'll complete this knee reflex. Can you see this knee reflex? If you ask the patient to do any of the knee extension or reflex, the knee is mostly supported by this femoral nerve, which is arise from L3 and S4, L4. So this ankle reflex, this toe and ankle pain. Clinically, हमको जब कोई बोलता है कि हमको toe pain है, तो most of the people think कि it may be rheumatoid arthritis or it may be arthritis. Ankle pain also, people have many diagnoses that it may be osteoarthritis and all these things. If you see in the knee, people usually complain कि मुझे knee पे pain हो रहा है, lateral side पे, medial side पे, thigh पे. So understand the root cause. अगर आपका एक arm खराब है, it doesn't mean the whole tree is having the problem, right? So there are two types of clinical pain. That is localized pain. Person will complain कि मुझे सिर्फ यहीं पे दर्द होता है. It may be traumatic or it may be other pathology. But most of the times we ignore in our OPD कि it is the root cause. It is this root cause, the lumbar, the sacral vertebrae, which gives rise to this femoral and sciatica nerves. It irritates. So the gold standard is that pain shooting down leg is equal to radiculopathy, and numbness patterns tells us कि किस पार्ट में पेशेंट को नम फील हो रहा है. मतलब वो पार्ट का नर्व या तो इरिटेटेड है, या तो कंप्रेस्ड है, या तो कोई भी स्टेनोस्ट है, और देयर आर मेनी अदर रीजंस यू कैन elicit. So another most common clinical patient you will see is of a sciatica. Can you see this redness? So this picture has been zoomed over here. As we can see, this is a sacrum of the patient. This is the iliac portion of the pelvis. This is the sacroiliac joint. And just below this iliac portion, you see this sciatica nerve getting arised. It is very a thick fibrous band which needs to be taken care of while operating, while treating the patients. You should know this is the sciatica nerve. So if there is any issue with this iliac portion, if there is any degeneration, if there is any kind of arthritis, if there is any kind of trauma, if there is any kind of pathology, there is any infection, if there is any compression, stenosed, so this sciatica nerve is getting irritated. Second, it is just in the front of this acetabulum of this femur, in front of acetabulum femur. So if you ask the patient to rotate his leg or do any flexion extension test, you will see that he will have that kind of irritation because this sciatica nerve is just very close to the acetabulum. So the pain from sciatica radiates from the buttock down the leg and can travel as far as feet and toes. My main thing is to focus clinically when a patient complains in any part of leg. It may be sciatica pain, it may be localized pain, it may be osteoarthritis, it may be rheumatoid arthritis. Find it well, do a very good clinical examination, you will obviously find out what is the cause. So how lumbar works? What is the function of lumbar? So lumbar has three functions. एक तो हमारा weight bear करने का, हम constantly बैठे रहते हैं. So it bears our load. It helps in the movement of the patient to flex, to extend, to bend sidewards, to rotate. It has all this physiology. And the third physiology is the nerve conduction, which gives a signal from brain to the peripheries and peripheries back to the brain. So it is very simple physiology you need to understand. I guess most of the people present over here knows this thing. So what should you do in your OPD basics? What actually matters? See, history taking is very important. Whether patient had any trauma, whether patient is having any local pain or radiating pain, you need to ask the patient history. Since how much time he is having, did he show to any doctor, what medicines did he take, what therapies did he take? It is very important to ask our history, because if we prescribe the same thing and patient don't get the results, it is the doctors get defamed. So proper history taking is a very good art. And next is examination. For examination, you need to see this inspection, palpation and movements. Inspection में हम क्या करते हैं? तो if the patient is standing straight, whether his curvature is proper, क्या उसका पोस्चर नॉर्मल है, क्या उसको स्कोलियोसिस तो नहीं है, and we see many other things in the spine. So while seeing also you will come to know. Second thing, if it is a male patient, you can undress them and see the spine properly, whether the curvature is normal, whether there is any kyphosis, lordosis, scoliosis, or any of those things. Don't hesitate to do a proper clinical examination. Next is palpation. You have to palpate whether the pain is at the center, whether the pain is at the sides, whether the pain is at the muscles, lateral part, where it is. For movement, you have to see the movements, whether patient is able to do the free movements, whether is there any, if he is doing slowly, or many people nowadays, when they sit for a constant period of time and when they get up, you see that their arch is changed for a 10 to 20 seconds time. That is because of there is some stiffness in their muscles. You need to relieve this stiffness in OPD. You need to improve the diet. You need to do all those management, which will be discussing in our future insights, clinical insights. And you need to run a very special test, SLR test, and many other tests. We will be discussing this clinical test in our next session. And you need to do a very good neurological examination where femoral stretch test is done. The patient is in the prone knee flexion is done, and in front of thigh you can see the upper lumbar L2 and L4, and the knee reflex will tell us the L3, L4, ankle reflex L1, and big toe extension L5. See, this is a topic where I'm trying to correlate this anatomy with clinical OPD. So next point is this facet joint. हमने स्पाइनस प्रोसेस पढ़ लिया, लंबार वर्टिब्रे देख लिए, इंटरवर्टिब्रल डिस्क के बारे में डिस्कस कर लिया था, एनुलस एंड द फाइब्रस पल्पोसिस. Now this is the facet joint. Why it is important? See, we'll jump on to the right side image which shows us the degeneration. This is also capsule. This facet joint is a capsule which contains of synovial fluid, a good amount of thick bands of you can see this membrane, cartilage. It is a very good cartilage. But here the cartilage has completely erupted. It is already inflamed, ulcerated. There is no synovial fluid and there is a good friction between these facet joints. This is small things which we miss in the OPD, which irritates the nerve. Can you see that it is irritating this nerve over here? Constantly patient is having that kind of pain. So the facet joint syndrome is something where this chronic back pain is caused by arthritis or inflammation or any kind of injury to this facet joints. So OPD mein there are most 5 common clinical cases which you'll see in patients X-ray, in clinical examination, in OPDs, in MRIs. So the number one is if the patient complains of muscle strain. As I said, labor workers do a very hard amount of work. मोस्ट कॉमन रहता है उनमें मैकेनिकल लो बैक पेन, बिकॉज ऑफ ज्यादा एक्सरसाइज, ज्यादा एक्टिविटी, ज्यादा स्ट्रेस, स्ट्रेन, रिपीटेशन की वजह से patient will have low back pain. That is called as mechanical low back pain. Second, if you have a radiating pain ka patient coming to your OPD, I am having this kind of radiating pain, you can consider it as prolapsed intervertebral disc disorder, where the disc gets prolapsed. As we can see in this, appreciate in this image, this nucleus pulposus is penetrating the annulus fibrosus and hereby compressing the nerve, stenosing the nerve. So this is the second most important case you'll see in your OPD. Third patient you'll see is of a old age patient suffering from a degenerative disorders, or may not be suffering from degenerative disorders, but having some kind of degeneration, age related wear and tear changes. You can consider this patient for lumbar spondylosis. We can see in this image, can you see the intervertebral discs are very small and the joints are got degenerated. The lumbar ends have got degenerated. The cartilages have almost weared out. So you can see the patient will have stiffness and pain. And if the patient is having pain on extension, अगर आप पूरा पीछे extend करने बोले patient को, and if the patient is having pain at that time, you can consider it as facet joint syndrome. Facet joint syndrome, as we discussed just recently, what is facet joint, what is facet capsule, and if there is any degeneration, arthritis, inflammation, so the patient will have facet joint syndrome. These four things can be clinically, at somewhat extent, can be treated with OPD skills. But if when to refer the patient is very important. If the patient is having any tumor, if you suspect any tumor in your OPD, you must refer it for further imaging and to a higher orthopedic surgeon. If there is any kind of infection, POTS, TB spine, you can say, then you should refer this patient. If the patient is having this cauda equina syndrome. Now, what is this cauda equina syndrome? So it is an emergency case. What kind of emergency? Let's discuss now. So can you see this? The term has been splitted. Cauda means tail. Equina is the horse. It is an clinical emergency. जहाँ पे due to this intervertebral disc or any vertebrae, these nerves are getting irritated and it is an emergency condition. The patient will have this severe low back pain. There will be perianal numbness. The patient won't have any sensation. Then you need to think there is some compression of nerves. If there is any bladder bowel dysfunction, if there is any bilateral leg weakness, reduced reflexes, this image clearly tells us everything. This is an clinical emergency where an emergency MRI needs to be done and early surgical decompression within 24 to 48 hours. Messages: never miss CES in low back pain. Early diagnosis prevents permanent disability. So don't treat all the chronic low back pain cases with the same. Some might be emergency. So you need to rule out this in clinically. So quick OPD thinking algorithm for low back pain is: patient comes to you with a low back pain. Ask, localize है कि radiating है? If he is having just pain, so you can treat it at the OPD level. अगर pain है तो you can treat it at the OPD level. But when the patient complains of numbness or tingling, and that too जितना ज़्यादा period रहेगा उतना ज़्यादा problems रहते हैं. So if he complains of numbness or tingling, you need to see that there is any neurological deficit. With some medicines, we can suppress to certain levels this numbness and tingling, but we need to correct the anatomy. We need to correct those herniation, stenosis, narrowing of neural foramina, and all those things. We need to do the anatomical correction. So these are the three things you need to remember: the pain, numbness, tingling. If pain, yes, you can solve at certain level. If there is numbness and tingling, try to correct the posture mechanically through physiotherapy, through many Bhaya procedures, we say external therapies. So this is the most final clinical pulse will be that most back pain is not serious. MRI is always not the first step for the patients. Check for the neurological symptoms. If there, don't miss Cauda equina syndrome. I would like to thank my guru, Dr. Mahesh Sanghvi sir, who I guess sir is not available for today because he is out of station. Thank you so much, sir, for guiding me so much. This is myself, Dr. Nikhil Gupta. So now the session, now we can open this floor for questions. Please feel free to ask questions related to today's session, what we have discussed. What is their inputs? You can put your questions. The floor is open for the questions.
Nikhil, it is in a nice explanation. I have
Thank you so
joined
much,
before
sir.
45 minutes. I before joined you 45 minutes before. Came
So
out
sorry,
from the
sir.
conference and I joined you. Excellent, excellent explanations and lucid slides.
Yes, sir. Thank you so much, sir. Is there any questions for today?
Everybody can ask, I'm here only since last 45 minutes, silently listen the Nikhil. It was an excellent, and I'm very happy. He is better than me in anatomy and clinical science.
No, sir. I've learned these practical things to correlate from you only, sir. Thank you so much. So there is a question by Dr. Dev. So the symptoms are low back pain since 2 months. Pain is radiating from to the right leg since 1 month. Tingling and numbness is also there. Right foot since 15 days. No diabetes, no hypertension, no spinal surgery. All vitals normal. Posture slight forward bending में. Gait is antalgic gait present. And tenderness at L4, L5 region. MRI shows that L4, L5 nerve compression route. What is the best treatment protocol in this condition, sir?
What you suggest? First,
Hmm?
you answer. What you
See,
suggest in this condition?
yes, sir. See, this is a, as Dr. Dev has put a very good question, a very practical question where it has clearly mentioned in the MRI reports that L4, L5, and S1 mein there is somewhere root nerve compression. So because of that, second thing is the patient is having that radiating pain. So there is some irritation at that L4, L5, S1, which needs to be corrected, which needs to be free of. So our main focus should be on those lumbar and lumbosacral area, the treatment to free that area.
So what you advise in this condition? If you are a surgeon, if you are a healer, then what is your choice of the treatment?
First thing, if clinically, I would give some tablets to suppress the pain. And second thing, I will ask the patient to use the electrical heating pad to reduce the pain. And we'll give these tablets, internal medications, followed by Kati Basti and release. If we use the traction, my mechanical thinking is that we should use this traction to pull the legs, to free the spine, to free those intervertebral disc. So traction will give good results in this thing, along with internal medications to manage the pain.
Like, is it necessary to give the anacid or any painkiller in this case? No other
For
option.
no, sir. For early within the 5 days, we will prescribe. Then sudden, then dhire will taper off the dose and move on to the correction. This is a temporary effects. What we give analgesics and anti-inflammatory tablets, they will not correct the anatomy. They will just control that gate theory mechanism जो हमारे brain को लेके जाता है, all the pain sensation. It will block those nerve signals, but it won't correct the anatomy. So for certain period it is okay, but for long-term relief we need to do the anatomical correction, sir.
How we do? See, what I do in your case, if I am the healer
Yes,
and
sir.
his case came to me, first things you should have a first step is, the traction, number one. Number two, you should have, the hit pad along with this Arkapatra, Erindapatra or anything or a Patra Potli sweat. This is the second step. And third thing is we have also very good analgesic material in the Ayurveda. Something like a Jorankush, the Vadgajankush ras. If it's in arm, then you have an Amvatari ras and everything. Uh, when you remember all these, our colleagues, when the patient come to you and you prescribe the any allopathic medicine or a dispense, 80% is his faith on Ayurveda and you will be vanished. Try to understand them, convince him. And second thing is that, there is a lot of local application which reduce the pain. Think on this line, number one. Number two, you can use any, the pain material nowadays, the cannabis material is available from Delhi companies, which is reduce this in a small dose and a sustained release dose also. But If you give a traction and you hit pad along with this, the uh, Vedana Stapaniya Ganapatra or weight or a land, patient will be happy. And another thing is that applied any gentle, the any oil or liniment or anything, whatever you have, or any pain material you have, and give, the Nadi Sweda with the Nigrodadi Gana, patient will be relieved for the long time because all this material will be prescribed from the NSAID that is block the brain as you suggest that. But
Yes, sir.
this is for an habit, the creation material. As
Mhm.
soon as pain start, patient gulp the tablet. So why should he come to us? Think on this line when you think. Practice is a deep for. In GP, you can do anything, but when patient come to you, no, you can. My pleasure. You should. That's yours. Thank you. So sorry. Still, I'm in conference. But when the patient come to us, you should have to think about that. Now, in this condition, will you prefer Agni Karma or with Karma?
Sir, I will prefer Agni Karma in this session.
Why?
Because two things, it will improve the circulation. So basically, there is now root compression, so it is irritating the nerves. So it increases the blood circulation, and second thing, it will free the muscles. It will give
Excellent
a
choice.
yes, sir.
It is an excellent choice. And Agni Karma, immediate you do the Agni Karma, patient will be happy. You don't require further more.
Yes,
You,
sir.
you know it's very which are the points because you explained very well the anatomy. So at the point when you give this Agni Karma, it will be, as you said, blood circulation is improved. Number one. Number two, the spasm has been released, and that's with the tractions. If you do this one, patient will be improved immediately. I think so. This is the best answer from your side. What is the
Yes,
next question? You just can't come to it.
yes, sir. Another question we have: what will be the line of treatment in piriformis syndrome, sir?
Which is
Piriformis syndrome. It is a very small muscles like an appendix near our
right.
spine.
What
And
is this clinical symptom? You explain me because I was not full time with you.
yes, sir. So the piriformis syndrome is something. It is clinically correlated, not exact correlation, but you can correlate it as gridra, a
Okay,
sciatica. So what will be the
right.
treatment, sir?
But now the sciatica, what type of compression he has, which the area of the nerves has been this affected, and you have explained well, from L3, L4, L5, S1 connection with these clinical symptoms of that. So if it is there, I think so. Again, you should have to choose Agni Karma or Vidya Karma first. That's number one. If
Yes,
there
sir.
is an arm or any compression very big, then you should have to create the Agni Karma. And if it's no one, then you can give, the with the karma, it is also giving the same result. But you should be
Yes.
differentiate Sham and Niram, and then you will get a best answer for this. What is the next question?
Thank you so much, sir, for deep full insights. And the next question is that जैसे कि एक ओल्ड एज पर्सन में क्या डीकैल्सिफिकेशन होता है बोन का जिसकी वजह से बैक पेन होता है पेशेंट्स को तो ऐसे पेशेंट्स को हम क्या कर सकते हैं सर?
See, if it is a Akshikshaya, what I mean, understand and justified. Am I right? Clear,
Yes,
Nikhil?
sir, absolutely. Yes, sir.
Right.
We can
So,
clinically
so
prove.
then nothing, you should have to improve the blood circulation by any way, rest, and support this, lumbar spine, the belt, and improve this with the Kshirabasti. If it is a Niram, then you give with the Kshirabasti, or you can give in any Ayurvedic Shuddha Saptak like medicine, which has been increased this one. But thing is that when you prescribe inside, you should be assured that the Agni is good. Already you have said that it's an old patient. Am I right?
Yes, sir,
And
absolutely, sir.
then there are the Vayu Vriddhi is there. So
Yes,
at the
sir.
same time, Ashwagandha, Grita or anything, which has been improved that, it will be best. So internal, I think a lot of, in South India, there are a lot of tablet is available in oil form. These solve both the problems.
Yes, sir.
It is a long standing, the treatment, and it is not a curative. But first thing is stop the degeneration. then it support to reduce the pain and management and the muscles and everything. Here, Kati Basti is also more important to support the muscles in a long time. Any more questions?
Mm, yes, sir. We have a extension of the same question. How to avoid this condition, sir? What will be the supplements we should give in diet? Dietary advice. Dr. Rahul has a suggestion. What will be the dietary supplements we'll give?
Number one, first you have to find out whether he has no morbidity disease like a madhumeka and blood pressure and other, the heart disease or renal failure, thyroid and etc. If it is there, you should have to control. Then second thing is that your agni should be very good. As a
Yes,
system should be very good. In old age, this is very bad. That's two
yes,
things
sir.
you have to improve. And then you should have to give, the perfect digestive systems of व्यक्तिगत चिकित्सा समर्पण करके उनको देना चाहिए. वहां पर हमारा ये this thing is that which are the calcium rich diet, which are the protein rich diet, because when you strengthen the muscles, protein is more required in old age. These are the lifestyle management. You should have to find out and you have to promote this and counsel the patients.
Yes, sir. Absolutely. I guess 50% of the treatment sir has shared with us today only. And thank you so much for today's lecture. Any more questions?
Thank you. Thank you very much. I have to join. There is the one more section.
Yes, 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 sir, yes, sir. Thank you so much
If
for your
you
time.
allowed me, I will beg pardon. I beg pardon not to complete, but you have done very well. I'm very happy and proud of you that you have been done very well. And God bless you and further improve more to clinical experience with these anatomical structures. Thank you very much.
Thank you so much, sir.
I can I leave it?
Yes, yes, sir. Absolutely, absolutely, sir. Thank you so much, sir.
Thank you very much. Thank you very much. God bless you, everybody.
Good day, sir. Is there any questions? We'll see a last minute. Just a minute. Yeah. So thank you everyone for joining today. I would like to thank my teacher, my mentors, my colleagues, and my juniors for this support. So because of them, who I am today, I've been shaped with because of them. Looking forward to stay connected with you. Thank you so much. See you this Tuesday, coming Tuesday. Join the group. Hari Om. Shubh Ratri.